All right, if you can have your seat, we'll resume our scientific program for the morning. I'm Gene Moore from Denver. I'd like to introduce the next discussion. That will be physician representation on social media, a boon for females and surgeons, done by Drs. Fadi, Khan Mohammed, and Tafi, and Dr. Fadi will present.
Hi, my name is Negin Farai, and I'm a pre-medical student. Thank you to the association for giving me the opportunity to present our research on physician representation on social media, a boon for females and surgeons. Thank you. We have no financial conflicts. However, all authors have active profiles on various social media platforms. We sampled Instagram for public physician accounts in the United States. As you can see, a public account is one that displays all information readily available for anyone to view, and anyone can follow, whereas a private account has limited information displayed, and a follow has to be requested. Our inclusion criteria and data capture consisted of the mention of a physician or doctor in the bio, again, a public profile, the number of followers, the number of posts, specialty, as well as gender. And we compared our data to the 2020 Physician Specialty Data Report published by the Association of the American Medical Colleges. We categorized specialty as medicine, so primary care, which included internal medicine, family medicine, pediatrics and geriatrics, medicine subspecialties, surgery, which was general surgery, surgery subspecialties, and then all other, which included anesthesiology, pain management, pathology, physical medicine and rehabilitation, psychiatry, and radiology, and radiation oncology. So nationally, there are 938,966 active physicians, and most of these physicians are male. They are also mostly allopathic MD physicians. The primary care specialty makes up 1/3 of the specialties of active physicians in the United States, followed by all other medicine non-primary care specialties at 21%. On Instagram, we sampled 2,291 physician accounts, and we found that most belonged to females. Most were allopathic MD physicians. However, we found that surgeons were predominant on social media compared to other specialties. So looking at the total distribution of our sample, we see that 61% of the physician accounts belong to surgeons and surgical subspecialty physicians, whereas about 30% belong to medicine and medicine subspecialty physicians. So comparing our national data with our Instagram physician data, we saw that there were significantly more females on Instagram compared to the national physicians. However, there was a similar distribution of MDs and DOs. Additionally, we saw that national physicians are significantly more likely to be primary care physicians, whereas Instagram physicians are significantly more likely to be surgeons. So further looking at surgeons, both nationally and on Instagram, we saw that Instagram surgeons were significantly more likely to be female compared to national surgeons. About 55% of Instagram surgeons were female, whereas nationally only about 30% are. So the top 10 most common Instagram physician specialties can be seen in this graph. Plastic surgery, dermatology, and obstetrician gynecology were amongst the 3 specialties with the most accounts. There were 521 plastic surgery accounts, 302 dermatology accounts, and 176 obstetrician gynecologist accounts. However, nationally, internal medicine, family medicine, and pediatrics are the most popular specialties with the most active physicians. So we categorized influence depending on followers and posts that each physician had on Instagram. On average, in our entire sample, we saw that physicians had an average of 22,406 followers and an average of 411 posts. And the specialties with the highest average followers were transplant surgery, family medicine, and dermatology. So we further categorized and minimized our sample to be influencers, and we categorized that as those who had over 100,000 followers on Instagram. And out of our 2,291 accounts that we sampled, only 90 had over 100,000 followers. They had an average of 377,289 followers and an average of 1,575 posts per account. Interestingly, these were mostly belonging to males and surgeons. So then we further categorized our influencers to see who had over 1 million followers on Instagram. And out of the 90, 6 had over 1 million followers, and they ranged in 1.1 million to 4.1 million followers and belonged to plastic surgeons, dermatologists, and family medicine physicians. Interestingly, the top 2 physicians with the highest number of followers were a male family medicine osteopathic physician and a female allopathic dermatologist. So I know this is all like very cool and interesting, but you may be wondering why we performed this study. So currently there's a projected physician shortage by 2034. It's projected to have between 21,400 and 55,200 primary care physician shortage and a 33,700 to 86,700 specialty physician shortage nationally. And these shortages are even more so in rural areas as they have a larger gap in the patient-to-physician ratio. There's about 46.4 primary care physicians per 100,000 patients in rural areas versus 53.3 primary care physicians per 100,000 patients in the urban and metro areas. Similarly, there's 23.8 specialty physicians per 100,000 patients in rural areas and more specialty physicians per patient in urban and metro areas. And currently about 20% of the US population lives in rural areas. So it has been shown that media can affect physician career choice. The beginning of shows like Grey's Anatomy, ER, House, increased interest in specific residencies such as surgery, emergency medicine, and medicine. Social media can also impact medical specialty interest, and it can increase interest in medicine among just the general public. Social media can also increase the knowledge of medicine among the general public and increase their public health awareness. During the onset of the pandemic, Dr. Mike reached out to Dr. Fauci to provide information to his followers, as did many other physicians. So again, what does it imply? I don't know, she's talking about social media, it's a surgical conference, doesn't make sense. So like I said, currently female physicians make up a larger portion of those on social media and on Instagram. And as we know, about 52.4% of medical school matriculants are female, so there are more females going into medicine. However, this predominance is not seen nationally. There's a 40% gender gap in active full-time employed physician, and there is a higher attrition rate among women in medicine. So the hope is that this may be predictive of a future trend and a future way that physicians will increase their prevalence, but we have yet to see. Studies have shown that social media can have a positive impact on role modeling, on the advancement of women physicians, as well as same-sex mentorship. So our study did have some limitations. One, we only looked at public accounts and we did not look at private accounts. Two, although we were diligent, we do not know the real total denominator of physicians on Instagram. Three, we did not cross-reference with the National Physician Database. Four, Instagram does not readily provide age-related data, and we did not seek this information out, so no comparisons can be made to the national age of physicians. And five, we did not confirm the validity of the claims that were made by physicians on Instagram. So in conclusion, social media can influence female interest in medicine, it can create gender equality in medicine, and it can alleviate the specialty physician shortage. However, it can also negatively impact the national directive to increase primary care physicians. Thank you.
Dr. Kanai will open the discussion.
So congratulations for your presentation, and thank you for the opportunity to review your manuscript in advance. This study comes at a time where social media has led to dynamic political movements and fueled national debate. We also have used social media to question the ontology of a surgeon with the hashtag #ILookLikeASurgeon. We have critiqued gun control advocacy with "Not in My Lane," and the nature of online medical professionalism with the hashtag #MedBikini. We have transformed the diversity and inclusion of programming of our own educational conferences with the hashtag Mantle and MantleWatch. And we now have medical students and residencies promoting themselves for the ongoing virtual interview season with coordinated social media campaigns. About a decade ago, Dr. Faris Tamimi first questioned whether there was an ethical imperative for doctors to participate in social media, highlighting the importance of advocacy to promote public health and counter anti-vaccination movements. The pandemic has made this more obvious, but also has highlighted ways social media has helped some of us maintain a sense of community, stay current, lift our spirits, and even laugh at ourselves a little. In regards to the burgeoning use of Instagram by physicians, your study introduces data exploring the whom, but I would like to further explore questions relevant to the content these physicians are passively displaying and actively promoting. These will be the what, the why, and the how questions, exploring the balance between harms and benefits, with greatest respect given for our fiduciary duty to protect our patients and ideally a positive intent to protect the public trust. Firstly, your data shows the majority of Instagrammer physicians are plastic surgeons. In reflection of the important role of commodification, my first question reflects on medical professionalism and the ethics of surgeons marketing their services, specifically with the use of video and photography that may include patients or influence future patients. My second question relates to the discourse between the surgeon and the public. Are surgeons using this medium to educate or directly communicate, and how is that conversation managed? More specifically, what are influencers doing? And thirdly, in 2013, the American Board of Internal Medicine Policy suggested that physicians keep separate private and personal accounts, a somewhat schizophrenic and impossible goal. Your data highlights disproportionate rates of women physicians participating in Instagram. My third question goes a little beyond gender and more to authenticity. Does authenticity in expression of self matter when it comes to connecting with others and influence? Thank you to the program committee for the opportunity to discuss, and Dr. Moore for the floor.
Go ahead, you can answer those in sequence.
I will. Thank you very much. Thank you, Dr. Gbai, for your insight and for the opportunity to have you discuss this paper and review our manuscript. So many of you may already know the American Medical Association, the American College of Surgeons, and specifically the American Society of Plastic Surgeons have very clear guidelines on the Code of Ethics, which includes social media use. And any of you that are part of an institution should be very well aware of your institution's policy for or against social media. I agree that in general it's important to represent our specialty in a very professional way and to follow those. And even the ASPS, the American Society of Plastic Surgeons, has the strictest code of ethics when it comes to that. and has removed many plastic surgeons because of their violations of their ethics policy. Of course, we want to make sure that patients are treated respectfully, they're consented, there's no HIPAA violation, there's no age discrimination on social media, so a 3-year-old and a 100-year-old can easily look at the same post, so that also needs to be followed. So I would say that, yes, it's very important that we do follow that. I do believe, though, that social media can be used in a wide variety of manners. You can do it for education, advocacy. It could just be something not that meaningful, just a way to express yourself. And many use it as a marketing tool. And each surgeon or physician has a certain goal with their profile. Some have no goal. But it's very important to understand, and I think to show that I do believe that with physicians coming onto social media, they are exposing themselves to the public, and that's something we have not done a very good job before. I would like to say my own specialty, I'm a hernia surgeon. There's a lot of backlash on mesh and how surgeons can be evil. And by being on social media, you are humanizing yourself as a physician and somehow reducing that barrier, that hierarchical gap, which I believe contributes to the mistrust of medicine by patients when they see that you're caring and you're knowledgeable and you're sharing your experiences. I think that's a positive thing in social media. And then in terms of your comment about authenticity, females tend to be doing better on social media. It seems to be more comfortable for them. Our leadership traits are a little bit different. The whole topic of feminine leadership traits, where we believe in authenticity, more humility, inclusivity. Those are all things that are much easier to portray on social media than, let's say, at a society meeting or in the leadership of your kind of academic leadership. So I like the fact that women are being empowered. I myself have really done very well in having women as mentors, and I see that those that are women considering surgery or considering medicine do that in a stronger way when they see that there's someone above them further along the career that they can kind of role model against. So thank you for your questions, and I'll take any more.
We'll just alternate, and please ask simple questions. We're getting a little short on time, please.
Yes, thanks, Dr. Moore. Thanks, Dr. Tofai. Interesting data. As a recovering surgical program director and current designated institutional official, I have to tell you that despite its benefits, I've developed an allergy to social media. So I understand that every institution will have a very detailed social media policy. We certainly do. Many of the specialty societies do. Yet, when we're dealing with digital natives who are coming up, through the ranks, are there in existence practical guidelines? Have you devised practical guidelines that'll keep people sort of centered in the lane and keep it entertaining yet compliant?
Thank you. Well, as with all allergies, there's treatment for it. And also, just know that we don't have good answers. This is all flowing, and we're learning more as we deal with more issues related to social media. Thank you.
John Corson from Albuquerque. So I'm a little concerned about some of your conclusions. You sort of speak as though the only people on social media are physicians, but if I was a young person and was looking at social media, I'd be very tempted by a lot of these entrepreneurial and business opportunities that are posted out there. I think there's a lot of competition for people's attention and career choices, and therefore just to assume that physicians are the folks who would be reading this stuff and selecting a career might not be a valid conclusion. I would be very tempted to go into business after reading my social accounts.
So I agree with that, and I think that physicians in general have done a poor job of role modeling and mentoring out in the community. If you come from a family of physicians, you're more likely to become a physician, whereas if you're not exposed as much to physicians, at least before social media, you are less likely to choose it as a career. So I feel that those gaps and barriers are being torn down by social media because it is open to the public and internationally.
Good morning, and thank you for your presentation. I'm Tyler Hughes from Kansas, and I have a little experience after 9 years of running the ACS communities, which is, I've developed a type 4 allergy at times, and I am undergoing treatment. But in all media, content and message are king, and your study really doesn't tell us what the content is. It would seem to me that a qualitative analysis of these posts would help us determine what's marketing, what is promotion of the profession, what is unprofessional behavior and how common, especially among who are the ultimate influencers, those people with 1 million or more. What is their message and content versus, quote, the average physician? Do you have a plan to do qualitative analysis of this so that we can see some more association and causation analysis with this? I think that would be very helpful and would help organizations like this define our message on social media.
That's a very good question. There are companies that can provide you with deep dive analyses of posts. We've actually published on that before, where you can analyze Facebook, Instagram, et cetera, based on negativity versus positivity. So how is the discussion a negative discussion or a positive discussion related to a certain account or a certain hashtag? And also it can give you a little bit more granular data. The problem is that we're looking at physicians alone. It's really hard to, there's no good computer-based way to analyze that. And Nagin did an amazing job. She spent, I don't know how many months. I think she became allergic to Instagram too by the time she was done with this. But this was her project. She came up to me and said, I want to do this study. It was completely her idea. And the fact that we came up with these really interesting demographics and statistics, I thought was eye-opening. And thank you very much to the association for allowing us to present our data and have this discussion.
Thank you. Our next presentation is the contemporary practice of general surgery in the United States, an analysis of the American Board of Surgery's diplomat case logs. Authors are Doctors Cortez, Jimenez, Marino, Jones, Berry, Valentine, and Potts. Dr. Cortez will present.
Thank you very much, Dr. Moore, and good morning. Thank you to the Western Surgical for the opportunity to share work today. As he said, I'm Dr. Cortez from the University of Cincinnati, and I'll be presenting on behalf of our group. We have no relevant disclosures. The process of certification by the American Board of Surgery has evolved over the years since its inception in 1976, and in 1994, it became required that diplomats submit a case log in the year prior to their recertification. The point of this was to allow for combination and to create a unique data set with both case logs and surgeon demographic factors to study the scope of practice of practicing general surgeons as well as subspecialists. Not only does this allow us to study the scope of practice, but we can also look at surgeon volume, and there is data that supports that surgeon volume correlates with outcomes. And so understanding these trends of practicing surgeons is very important. And these data inform multiple aspects, not only of surgical practice, but also of resident training. By studying the scope of practice and what surgeons are doing, we're able to understand some supply and demand trends across the country. This informs and revises exam content that's set forth by the ABS, both for certification as well as the ABSITE and qualifying and certifying exams. It may shape CME programs and their content, and then has a trickle-down effect on trainees in that it can be used by the ACGME as they set forth case minima, and that has an impact on the residency programs and how rotations are structured and what their curriculum entails. Prior work using the case logs by the American Board of Surgery have been done twice prior in the 90s and 2000s by Drs. Ritchie and Valentine, both presented at the American Surgical and published in Annals of Surgery. Therefore, this is a hypothesis-generating project and serves as a follow-up in the contemporary area to study trends of the general surgeons in the United States. The aims of our project were threefold: to to describe the composition of today's practicing general surgeons, to examine the scope of practice of these surgeons, and to study variance among U.S. general surgeons with regard to their practice patterns. To do this, we performed a review of all applications for ABS recertification from 2013 to 2017. To remind the audience again, they apply every 10 years in this data set, and the case logs are representative of 1 year prior to the recertification. The surgeons were then categorized as either general surgeons or subspecialists, and the latter group was identified as subspecialists if they had a concomitant certification in either another American Board of Surgery specialty, a specialty of the American Board of Medical Specialties, or if they were identified as a transplant surgeon, which was defined as having done either a kidney or liver transplant in the year prior. And any surgeon with less than 100 cases, which was the lower 10th percentile, were excluded as they were considered to be minimally active surgeons. The demographics we had access to are listed here. Of note, time since initial certification represents being an early, mid, or late career surgeon defined as 10, 20, or 30 years into practice. And consistent with the prior works, we identified and categorized practice setting using the rural urban commuting area codes with population sizes listed here. Sorry, I'm not sure how to get at that. There we go. For statistical analysis, we did two complementary methods. First, we did a factorial ANOVA, which is similar to a standard ANOVA, however, allows for incorporating multiple independent factors and allows for some controlling for confounding and interaction effect with p set at 0.05. And then to look into practical effect, we utilized a statistical test of effect size using the omega squared value to understand the magnitude of a significant p-value. And that was defined as an omega squared greater than 0.01. Looking at our data, first, in order to understand the composition of surgeons, we need a comparator. And so we compared the 4,500 general surgeons to the 2,500 subspecialists in this data set. On average, general surgeons were slightly older, had a larger proportion of female surgeons, and were similar with regard to international medical graduates. With regard to the practice setting, there was a larger concentration of specialists in the urban environment, setting, and then more general surgeons in the rural and isolated area. And with regard to time in practice, there were more early career surgeons in subspecialties, which is consistent with well-documented phenomenon that more and more graduates are going into general surgery and more into subspecialties and fewer into general surgery. Looking at where residents are, what they're going into out of graduation, we see here the 5 regions of the U.S., and there's a near even proportion of destination, whether it's subspecialty in yellow or general surgery in white, except for the Northeast, where we see a larger proportion of graduates going into subspecialties. And similarly, once these surgeons are in practice, looking at their regionalization, we see similar trends with a slightly higher concentration of specialists in the Northeast. And finally, if we compare our data to that of Drs. Ritchie and Valentine, over the past 20 years, there's been a large increase in the proportion of female surgeons from 5 to 20% over the past 20 years. Next, looking just at the general surgeon cohort to understand their operative experience and scope of practice, this is a typical operative profile for these surgeons. We see that the largest contributions to their operative volume are cases within abdomen, alimentary tract, breast, endoscopy, and other, with the most significant operations in abdomen being biliary, which is primarily gallbladders and hernia, and then for alimentary tract, large intestine, which is predominantly colectomies. General surgeons in the United States, on average, contribute 430 cases to the needs of our country per year, of which 20% are on average performed in a minimally invasive fashion. Next, we then looked at total case volume among surgeon subgroups, and we did this for each of the demographic factors that we had in our data set. So moving left to right, if we look at total volume among the general surgeons by region, we see that surgeons in the Northeast and in the West perform fewer cases than their colleagues, with surgeons in the Midwest performing the most, about 130 more cases than the Northeast and West. Looking at practice setting, surgeons in the urban area perform fewer cases than the rural or isolated surgeons, with large rural surgeons performing approximately 220 more cases than those in the urban setting. Male surgeons are on average perform 140 more cases than female surgeons. And surgeons by length of time in practice, the mid-career surgeons are the most high operative volume, performing approximately 60 more cases than early career surgeons and 40 more cases than late career surgeons. Next, we performed a multivariable analysis to identify factors associated with being a high volume surgeon, and a high volume surgeon was defined as being in the top quartile among all surgeons in the data set. We identified that male sex and being a mid-career surgeon were positively associated with being high volume, with the odds ratios listed here. And then age, being in the Northeast and in the West, were negatively associated with being a high volume surgeon. We did not have access to the raw data from the prior studies to allow us to examine trends statistically over time. However, we did qualitatively compare these, and looking at the proportional experience of our data compared to that in the 90s and 2000s, we see a slight increase in the domains of abdomen and alimentary tract, as well as endoscopic procedures, and this is at the expense of fewer breast, soft tissue, and vascular cases performed among the general surgeons. And to no surprise, there's been an increasing proportion of cases performed in a minimally invasive fashion, increasing 9% since the mid-90s. Our data has its limitations. First, it's a very large sample size, which can result in detecting statistical differences where may not be large clinical difference, and so it may introduce type 1 error. For this reason, we performed our complementary method of analysis using the effect size, which identifies a magnitude, and so that is the omega squared value, and allows us to see what the magnitude of that statistical significance may be. Additionally, there is very large variation among each and every surgeon, regardless of what demographic they're in. In Dr. Ritchie's first paper, he commented in that manuscript that we should not fall for the tyrant of the mean. That is, we are looking at aggregates. We have to recognize that every surgeon has a very different practice pattern, and that should be taken into account. So in conclusion, the composition of general surgeons in the United States over the past 20 years has remained relatively stable, except for a very large increase in the proportion of female general surgeons. The scope of practice has shifted slightly over time, but still remains very broad, and there remains large variation among general surgeons. And finally, periodic reevaluation of these data are important both at the local and national level for training of surgeons as well as practicing surgeons. And thank you. Happy to take any questions.
Discussion will be opened by Dr. Jarman.
Yep, so Ben Jarman, La Crosse, Wisconsin. Members of the Western Surgical Association, I really appreciate the privilege to discuss this work by Dr. Cortez and co-authors. This is an analysis of American Board of Surgery diplomats' self-reported operative experience from 2013 to 2017. Dr. Cortez, in combination with his co-authors, have a fairly rich history of assessing operative volumes as reported by both residents and general surgeons with a focus on biliary, vascular, and pediatric procedures in the past, and this is an adjunct to all that work. I appreciated being forwarded the manuscript ahead of the presentation, and as noted transparently, this is really just a descriptive analysis with regard to previously reported data and then some assessment of trends over time. There's no doubt that studying what surgeons do is important on many fronts, which are well outlined by Dr. Cortez. The authors note several positive findings, which I'll not review, but notably, general surgeons operate a lot, and the breadth of procedures performed by our colleagues across the country is something to really be appreciative of and should really inspire all of us. So a few questions. First, with regard to the categorization of general surgeons, how are those who have completed minimally invasive fellowships designated? This is noted to be the most common fellowship pursued by our residents. And my observation is that there's a large variation in practice patterns and location by that population of people. So how did you account for that designation in your study? And if not, is it possible to further evaluate that group? Additionally, there's a couple other categories like that, people that have completed a trauma or acute care surgery fellowship, or those who've completed non-ACGM accredited critical care fellowships. How do we account for those? Second, there's national concern with the current lack of rural surgery access with anticipated exacerbations over the upcoming 10 to 15 years, owing to the noted older age, that greater than 55, of rural surgeons, and really a lack of definitive continuity plans. So would you please just comment on the association you noted between late career surgeons more often being general surgeons versus subspecialists? And was there a regional impact to that? I know you separated out by region, but not by age. And I was wondering if there's a certain region where there's an older population of surgeon. And again, with Dr. Potts, with your experience and wisdom, what actions do we need to take, if any, to address that issue? And third, regarding the finding that male surgeons report higher volume of operations despite an increased and great representation by females. Number one, does this matter? Is this something we need to pay attention to? What concerns, if any, do you have with that finding? Does the ABS reporting mechanism capture full-time equivalent status among diplomats? And do you think variations in clinical FTE could account for that difference? Or is this an equity issue that we really need to be aware of? How would you propose we further study that finding? Thank you for the opportunity to discuss the paper.
Go ahead, John. Yes.
Well, Dr. Jarman, thank you for reviewing the manuscript and for your questions. Your first question was regarding the categorization of general surgeons. We chose to use the same methodology that Dr. Valentine, who's a past president of this organization, had used in his 2011 presentation, namely identifying those surgeons who were recertifying who also had another certificate from an ABMS member board, and we excluded those as subspecialists, leaving the rest as general surgeons. We recognize that there's an increasing proportion of general surgery residency graduates going into fellowship programs. You mentioned MIS and trauma critical care. But in fact, those individuals really are performing general surgery. They're doing it perhaps with a special technique or with a little bit more expertise in one area or the next, but they're performing general surgery. So we feel like that's fair to include those in the general surgery population. It would be great if we could further subdivide the general surgery population and get more specific information about these subgroups, but to my knowledge, the ABS doesn't ask for that information on recertification applications. Did you do a fellowship? So with these data, we would not be able to do that. Let's see, I think your next question was about the rural surgeons and particularly late career surgeons and that impact on regional care. Again, it's clear that there's a trend toward increasing numbers of general surgery graduates going into fellowships. That's been well documented over the last 30 years or so. Is there anything that we would recommend to do about that? Well, the fellowships just keep proliferating, and it's a free country. So I don't think from a regulatory standpoint there's anything that we can do about that. I think our obligation is to be sure that general surgery resident program graduates are at least capable of performing the broad spectrum of general surgery. Whether they choose to do that in the end or not, that's our first obligation, is knowing that they're capable of doing that. With respect to rural surgery, certainly the fellowships, or the rural tract residencies that have been created and are being created will help with that issue. I think addition of just simple rotations for those programs who don't want to form a rural tract or can't form a rural tract, simple rural rotations will be helpful in providing care to the rural population. One interesting thing is that when you compare our data to that of Dr. Valentine a decade ago, we actually demonstrated more rural surgeons in this study than he did in his. It's a small difference, but it is a difference. And let's see, regional impact, we did not analyze it in that sort of cross-sectional way, but we can do that, and I think that would strengthen the manuscript. You asked about, well, does it matter that females do fewer operations? Well, ultimately it could matter. It could matter if we have continuing increase in the number of female surgeons and if that gap persists. However, we know that there will be an increasing number of female surgeons. We don't know whether that gap will persist. We don't know the reasons for that gap. These data just don't tell us the reasons for that gap. One could speculate that the reason for the gap that we've seen is that more of the female surgeons are in that first 10-year group, and perhaps their practice has not yet matured to the point that they are performing the same number of operations as the average male surgeon over the 3 different decades. So another thing we can do before we finalize the manuscript here is go back and do that cross-sectional study of the 10-year recertification group and female versus male case counts in that group. Thank you for your questions.
Great discussion, but again, we're getting a little short on time, so if you can keep it direct, please.
Thank you. Mary Hahn, Stanford University. Congratulations on an excellent presentation. So I think this is great for describing what a general surgeon does, but case volume isn't everything in terms of work effort, and I think we have to be careful to not go to that this describes effort in terms of, is it 60 endoscopies versus one, major complicated inpatient operation. So I think we just need to keep that in mind when we're talking about what regions have more effort. I was surprised by the rural surgeon actually having a higher case volume, and I wondered if you looked at density of providers, surgeons per underlying population, and is it just that they have to serve there's fewer of surgeons, the density for that population compared to the Northeast or the West, and is that contributing to the average case volume of our rural surgeons, and are we just going to increase that disparity as fewer surgeons go into there in terms of getting critical access to care? So thank you for an excellent paper.
Again, we did not do that cross-sectional analysis. However, I would say that this is absolutely consistent with the findings in the prior studies by Ritchie and Valentine.
Very brief question. So I'm going to remember that tyranny of the mean comment. I would ask you to think about the minimum number of operations it takes that you have to do to be reasonably good at it. And I saw that the mean number of trauma cases was 3. So I think there's a real information that you could gather from this about people who do very, very few operations in certain fields and still call themselves general surgeons. And perhaps all of us, need to think about redefining what it means to be a general surgeon.
Dr. Stain, I think that was a statement, not a question.
All right, Dr. Harkin, finally a word.
I'm going to ask a question, but I want to also commend Dr. Potts on extraordinary authoritative but also professional leadership in one of our major regulatory groups within surgery. And the earlier presentation this morning, I was reminded of both the influence but also the power of social media. And I wonder whether there's an opportunity within the American Board, within the RRC, to incorporate some kind of question, some kind of sense of remaining professional, as you've demonstrated so effectively. Is there a way to use that power? I mean, I was frightened by the initial presentation about something I already knew, and that is social media has taken the place over. And we've got to learn how to control it. And if we don't learn how to control it within our own specialty, we're in real trouble. Is there a way to utilize your influence, which you've done so effectively by your personal activity, but is there a way to expand that within your regulatory capabilities? Thank you.
Well, I appreciate your question and your comments. I don't know offhand of a way to do this effectively as an accrediting body, but I think it's a challenging concept that we should pursue. Thank you, Dr. Harkin.
Thank you very much. And our final presentation for this session is when endoscopic therapies to treat upper gastrointestinal leaks succeed, predicting the probability of success using leak assessment scoring calculator by Drs. Chin, Leans, Sanchez, Rasmussen, Ogala, and Ward. And Dr. Chin will present. Dr. Chin, by the way, is a medical student.
I appreciate that clarification. So first, I want to start by thanking the WSA. We worked a lot on this, and I didn't think that I would be able to speak about it at this sort of function. So this means a lot to me, so thank you to all of y'all. Like he said, my name is Kevin Chin. I'm a fourth-year medical student at Texas A&M, and I'm doing my training at Baylor Dallas, and I'll be talking to you guys today about a scoring system that we developed for predicting whether or not endoscopic therapy will be successful in patients who develop leaks after foregut and bariatric surgery. So here are our disclosures. None are relevant to this presentation. So a quick introduction, GI leaks following foregut and bariatric surgery, commonly associated with significant morbidity and mortality. These leaks have traditionally required significant diversion operations. These carry their own, complications and management issues. The goal of therapy ideally should always be organ sparing, and in this case, endoluminal techniques have really flourished in this area. Previous studies have shown that 80% of leaks treated with endoluminal vacuum therapy have healed. So what do I mean by endoluminal options and endoluminal techniques? So what you might think of it is endoscopic therapy, and what might come to mind for some of you is stent placement, which I'm sure y'all are all familiar with. Something y'all might not be as familiar with is endoscopic internal drainage, shown here, and I will explain what that means in a second. And then lastly, endoluminal vacuum therapy, or EVAC. And there is what's called an endosponge. So if you guys aren't familiar with this, it's very similar in concept to what a wound vac is, but you just think of it inside a lumen. So here we have a video showing off endovac therapy. You'll see a lumen with a defect as well as a cavity. You identify it with the endoscope. And just pertinent to mention that this can happen anywhere along the GI tract. So you'll see here, bring in the endoscope with an endosponge. You put it into the defect, into the cavity. You hook it up to suction, and the defect will close. And with serial replacements, the idea is that with each one, the wound closes up a little bit more and more. After a few days, you change it out, very similar to wound vac. Eventually, the defect will seal, and it'll heal via secondary intention. So here is an example of internal drainage. You'll see GJ anastomosis, and on the bottom left in a second, you will see the defect. So you can see it right there. So first you'll see a wire going in to the defect, and then a biliary stent, which you can use, and it has a pigtail on both ends. The idea here is that you have one end going directly into the defect, and then the other end of the pigtail going directly either into the stomach or the rest of the GI for internal drainage. Okay, so why am I telling you guys about endoscopic therapy? We developed a scoring system, specifically a nomogram, that's capable of accurately predicting the probability of success of management of a leak endoscopically via the methods that we mentioned above. So quick sneak peek, this is the scoring system that we created, and I will be sure to explain this thoroughly. How do we do this? We used a database that we maintained from 2013 to 2021, maintaining GI leaks. Endpoints of success for us were success of leak closure in patients undergoing endoscopic therapy only, the ET group, and then patients requiring surgery, and this can include patients who initially failed endoscopic therapy and were transitioned over to definitive surgery, the ST group. So we used a multivariable logistic regression model to fit and identify the independent risk factors for predicting success of endoscopic therapy, and using this analysis, our nomogram was developed. So what do we find? We have 81 patients who had foregut leaks. I'll mention that, as far as I know, this is the largest database of foregut leaks. 59 were treated endoscopically successfully. 22 were treated with surgical intervention, either going straight to surgery or with failure from endoscopic therapy. So you can see there was some crossover. Here's a table of our results and statistical analysis. On the left, you'll see the independent variables that we checked to look for that were checked in relation to their relation to whether or not they needed definitive surgery or not. You'll see age, gender, BMI, white count, whether or not they had prior bariatric surgery, comorbidities including hypertension, CAD, etc. And then additionally, all endpoints involved with the ACS risks calculator were also submitted. So the nomogram itself. In order for the nomogram to be statistically valid, given that we only had 81 patients, only 6 endpoints could be used. Based on surgical expertise and the statistical analysis that we did, we identified 4 independent variables that we thought were the most important and related to endoscopic therapy success. This included age, BMI, prior bariatric surgery, and number of days to leak identification and management from their sentinel operation. So here's the nomogram itself. You'll see the categories that we deemed appropriate, including age, BMI, prior bariatric surgery, and number of days to leak. For each one of these categories, depending on the patient's characteristics, you get a score or number of points for that category. So you'll see here there's a scale for age, a scale for BMI, a scale for whether or not they had prior bariatric surgery, and a scale for number of days to leak. So you add up the points for each category and you will get a total score, and that can be brought down and correlated with a probability of success. So I'll walk you guys through a quick example as well. So let's say you have an 65-year-old. There you'll see that it's circled on the age scale. That corresponds to a score of 7 for this category. A BMI of 36, that'll correspond to a score of 4 for this category. If they have had prior bariatric surgery, this would correspond with a score of 0 for this category. And whether or not, and if they had 128 days from the sentinel operation to diagnosis of the leak, this would correspond with a score of 1 for this category. So for this patient and this patient's demographics and medical history, this would give you a total score of 12. If you plot that on the total points scale and bring it down onto the probability of success, this patient will have a little bit greater than 75% chance of endoscopic therapy success. So conclusions that we came with, we developed this nomogram to help with the decision-making process when a leak is encountered. The hope is that with physicians at different centers, this will be a really quick and easy scoring system to use, and it can guide therapy and management options, whether or not you need to transfer a patient to a more skilled facility with endoscopic experience, or whether or not you need to take them to somewhere with experience in definitive surgery. The idea or the goals are to minimize unnecessary procedures, limit prolonged hospital stay as well. So future directions for this nomogram is validation. We're using it at our facility currently to manage patients who come in with a leak after foregut or bariatric surgery. Our hope is that we'll be able to maintain data sets or obtain data sets with hospitals around the nation as well, de-identified to help validate this scoring system as well. So thank you for the talk, and take any questions.
Great job, Dr. Chin. The discussion will be opened by Dr. Binger Casey.
Thanks so much to the Western for the privilege to discuss this paper, and thank you so much to the authors for sending the manuscript ahead of time, which gave me the opportunity to study the data some more. So indeed, there's a large study, 7 years, 81 leaks, and both from the manuscript and the presentation, I'm not quite sure if everybody who had a leak underwent endoscopy and possibly surgery, or some just underwent surgery and never endoscopy, and how they were included in the study. But I'm presuming most of them had endoscopy, so about 70% chance of success, which is great. Endoscopy has changed a little bit over time. Would be nice to learn from your experience. Did we get better since 2013? Do we have a higher chance now with all the vacuum therapy, which you've beautifully delineated? Cool video. My questions are, what were the actual index surgical procedures? There may be a little difference between a radiated esophageal cancer and a staple line leak from a gastric sleeve, and the reader would certainly have some help understanding, you know, if I look at my patient, what should I do with them? And then what reasons or clinical situations did you make the decision to go to surgery? You know, was it different for bariatric or non-bariatric surgeons? Was it the prior bariatric surgery? Does it mean any reoperative surgery? You know, I converted failed Nissen to a Roux-en-Y gastric bypass. Is that the same as a prior failed gastric bypass? So what were your reasons there? And what are your plans for external validation on the nomogram? Thank you.
Well, thank you for the questions. It's a great honor to be here. Like Kevin said, I'm very proud of him. He did a great job putting all the presentation together and all the data. Thank you for looking at the paper. We did not include a slide with all the index operations, which I do have here. 64% of them were sleeve gastrectomies. The rest of them, it's kind of all over the place, total gastrectomies, subtotals, endoscopic complications, whether they were dilations or one was from a bronchoscopy. Roux-en-Y gastric bypass. We had 6 that were paraesophageal hernias and fundoplications. There's a category for spontaneous leaks, which is basically not iatrogenic. So one swallowed a bone that perforated his esophagus. One was traumatic. And then we had a couple from lung and liver transplant, and then esophagectomy in non-radiated fields. And so a very heterogeneous group of people. And so given the fact that it was so heterogeneous, that was the idea of the nomogram, was to take that prior surgery out of it and just look at factors that promoted healing. As far as the situations that prompted us to go to surgery, that's kind of what we're trying to figure out is, you know, try to eliminate that. Should we just go straight to surgery, or should we try endoscopy? Those endpoints that we found really are the things that started to shake out early on in the experience, and there was a learning curve associated with this. Those patients were eliminated from this because of that learning curve. We would do prolonged evac trials on patients when we didn't really know what was going on. And by the way, the evac is new in its birth. I mean, it was in Germany, overseas for a few years, but you know, we didn't start doing it till 2014, so we're still learning a lot about it. A lot of times, you know, you have to go patient by patient, which is, again, why this age comes into it and BMI come into it. But ultimately, endoscopic therapy was instituted on almost every patient. There was only one that went straight to surgery. And we would always judge it based on failure to progress, so we're just not getting anywhere. And usually I would, in my mind, always make it about a 2-week duration. So after 2 weeks, we're going to reassess. If we're not making any headway, then we're going to bail and go to surgery. In some cases with stents, we would go a little bit longer. We would trial them 4 to 6 weeks, and then we go to surgery. Now, you know, the patients at this point, these are chronic leaks, they're weighing in too. They don't want their stomach out, and so we really had to dance around a lot of this, and that's what focused us on the nomogram itself, is I want to be able to go in the room and say, listen, I can do this for a month, 2 months, 3 months, putting the vac in you, but you only have about a 25% chance of success. And so it was a tool to help us discuss that with the patients. The plans for validation, so as you can tell, the data range stopped January 1st. So since January, we've been collecting the patients that we've managed with leaks, and all we're doing is what we normally had done and just running the nomogram on them. And so we'll validate that internally, as well as we probably need to solicit externally and try to figure out if that can be done on other platforms outside of our hospital. That may be difficult because some places don't offer these endoscopic therapies that we offer. Mainly out there is stents. Most of the patients will get a stent right off the bat. And so this can be a difficult thing to validate, but we'll try our best based on what I discussed. Questions?
Mike Ujiki, North Shore in Chicago. Steve, I really appreciate you bringing your data to this meeting, and I hope that the association recognizes how important the data set that he has is. Most of us hopefully don't have 84 leaks that we can present our outcomes for treating. And you know, Steve and Mark, you get a lot of referrals from outside of your system to you because you've been so successful at treating these endoscopically. And it's really applicable to everybody in this room, because if you operate on the colon, the pancreas, the GI tract in any way, and you have a leak, Steve's group is showing us how to manage these in a non-invasive way. We all know that taking a patient back for a second operation a week or two later, or even a month later, it can be a disaster. And here Steve is teaching people around the country how to use the endoscopic vacuum therapy successfully. And now we're going even further, and you're helping us understand when do we use it. I really think that your paper will help us if you even just describe your experience. The nomogram is great, but there's also a lot missing from it, in my opinion. Not just other factors that might affect success, but also which therapy is best to use. Is it a stent? If somebody has an esophageal leak, should we be doing a stent? Should we be doing an evac? Should we do internal drainage? Should we just close it primarily if it shows up the next day? And I still don't think we really know that yet, but I think you guys can help us. And I think in your manuscript, if you could just even elaborate more on that and not get so caught up in the nomogram alone, because your guys' experience is one of the highest in the world, really. So really appreciate you bringing the data here. And then if you could just comment a little bit on the different options available, and then what you think, we should all be thinking about doing when we have a leak on our patients. Thanks.
Yeah, Mike, thanks so much for the comments. I think that the point of the nomogram for the basis of exactly what you're saying, guiding per therapy, what we want is for the surgeons to, or whoever gets the leak, to be able to use this and say, let's not keep you here, or let's not go to surgery, let's get you to a center that has the experience. And I think that's the most important part. I think just call me or call, transfer. And your point is valid that we are a regional center and we get a lot of referrals from outside. And so I think that if we can just guide people that don't have the ability to do evac, stents, endoscopic therapy, just get the patient somewhere that can, and we can spare this organ. As far as which to use, you're absolutely right. That is the next thing. We need to look at the durations. We need to look at what therapy they got, and then look at the demographics within each patient and try to tease that out. So that's coming. I think that's part of the other side of not validating this part of this science, but going the other way and trying to figure out how we can help the endoscopic surgeons out there and the savvy endoscopists to help them spare organs. So great comment, and that's exactly our visions align. Sir.
Collins, Los Angeles. I want to call out the beauty of your nomogram approach and using continuous variables. So much of the data we see is presented as binary. BMI less than 30, BMI greater than 30. Is it 32? Is it 62? This is beautiful. And I would just request that you take some time in the manuscript, or perhaps even a second accompanying manuscript, to describe your statistical methods so that the rest of us can benefit from this. It's beautiful work.
Thank you for the comment, and I can tell you right now that I don't understand it. So we would have to have that explained. I mean, our statistician is just, a wizard when it comes to this stuff. We put it on the table, and he'll tell us exactly what we can and can't do. And if I told you I can explain how he did it, I'd be lying to you, but I sit with him once a week, and I try to, okay, just tell me about this part, and it makes me feel that much smaller, but I think trying to understand this in the linear values, if you notice our BMI, it actually circles around. And we notice that the patients that have with a chronic leak and a lower BMI, I think they're falling into a malnourished, and that's why they don't heal well. And then the patients with the high BMI, especially if we're leaking in the belly, we're starting to see the trend towards, maybe the adiposity, or there's some inflammatory inhibition with, the obese patients that are preventing this. And so we're really starting to find kind of this trend in those areas by using the real linear numerics. Sir.
All right, final comment.
DeBoard from Peoria. It wasn't clear to me from your presentation on your nomogram the history of bariatric surgery. Did that refer to any remote bariatric operation, or that bariatric surgery was the cause of the index leak?
Yeah, that's a great question. In fact, that was something we probably should tweak in there. This should be any gastric surgery. You know, the majority of our patients are bariatric, but any gastric surgery, prior fundo, anything where you're compromising blood flow or scar tissue is created, that absolutely has shown in our data that increase your leak rate. And so we found that as probably the biggest difference, especially in the bariatric band to sleeve versus sleeve alone. We see a lot more leaks. I can almost tell you right off the bat when they show up at the hospital, this patient had a band because of the way they leaked. So I think any prior gastric surgery would influence this.
Thank you, Dr. Leeds.